Welcome to the Cardiovascular Pulse, where we dive into medical breakthroughs, leading technology, and healthy lifestyles. Join us as we empower you on your journey to a healthier and stronger you.
Hi, listeners. Do you ever feel fluttering in your chest or maybe like your heart has skipped a beat? Well, this could be a sign of a heart rhythm disorder. Joining me today is Dr. Kanwar Singh, electrophysiologist at Cardiovascular Institute of the South in Houma and Thibodaux, Louisiana, to discuss with us today those types of disorders, atrial fibrillation, what AFib is, why it happens, and some treatment options available. Thank you for being here with us today, Dr. Singh.
Happy to be here, Skylar.
Awesome. So I guess first off, can you explain to me about your specialty of electrophysiology? What is an electrophysiologist?
So, electrophysiology is a subspecialty of cardiology. Actually, the field started in late 70s, and the need for it was because of the rhythm disorders that were being very differently treated than heart attacks and blood pressure and other issues. So it became an offshoot from having a small training programs to large training programs and then spread out in the country. So it is an extra 2 years training after cardiology training. And we specialize and learn how to do different kind of procedures to treat different rhythm disorders, which can be fast rhythm disorders, slow rhythm disorders, irregular heartbeats, sometimes the risk of sudden death in patients, young people like athletes and otherwise who are born with some genetic conditions as well. So it treats a big portion of heart rhythm disorders.
Absolutely. Yeah. And I think you really hit on what the whole heart's electrical system is going, your heart's beating too fast, too slow, and it all goes in the same rhythm, right?
Right.
Right.
Yeah. So the electrical system can have issues with slow rhythm, fast rhythm, irregular heartbeats, or something that somebody's born with and puts them at risk of having a certain faint episode or a certain death episode. Sometimes that's how we find out first time that somebody has an issue. So electrical system, as far as the heart itself is a pump, but electrical system makes that pump work.
Absolutely. And we hear a lot what AFib is. You hear a lot about AFib. So what exactly is AFib and why is it so common?
Yeah, so AFib terminology is shortened for atrial fibrillation. The atrial word comes from the top chamber of the heart. Fibrillation basically means that it is a quiver or a shaking of that chamber. And when first defined, it is diagnosed as irregular heartbeat. So many people experience a little fluttering in the chest. But when we diagnose atrial fibrillation, we have irregular rhythm from the upper chambers. So normally, upper chamber beats one beat, it goes down to the lower chamber once, and that is a synchronized heartbeat. But every once in a while, the upper chamber can go into a multitude of beats. So you have 200 or 300 beats at the same time, which all cannot get through the chamber to the lower chamber. So you have an irregular pulse. So some beats get to the pulse, some beats down. So you have an irregular pulse and sometimes high heart rate, sometimes low, sometimes normal. And that will determine how patients will feel with AFib.
That makes perfect sense. And so I know you mentioned about how the heart can beat in different ways at different times, and maybe that's felt through, patients can feel that, people can feel that. Are there other symptoms of AFib? Can it maybe be silent? Other symptoms other than feeling those beats or your heart skipping a beat in general?
Yes. So about a quarter of patients actually don't know they have AFib. So, even patients sitting at home, feeling normal, doing activities and can have atrial fibrillation. So that's why it gets very important once you are of a certain age, usually 50 plus, that we want to have an EKG to make sure that the rhythm has been stable, which gives you a snapshot of the rhythm. But EKG is not always a definite way to diagnose. Now, the symptoms can be different. So some people, as I said, don't feel it. Some people feel a little fish flopping in the chest. That's very typical of explanation. Some people get dizzy or faint because the heartbeat is beating too fast. Some people have irregular heartbeat, so they get short of breath because not every beat is pumping the heart right. And so multitude of effects. And some people, unfortunately, present with a stroke. They don't know about AFib, and the first time we see AFib is they have a stroke. And unfortunately, we found out that many people who get stroke are not diagnosed with AFib at the same time. So in those patients, it becomes very tricky that we want to know if they have AFib that caused their stroke. Because in many studies we found out, and in one study they actually proved it, that about 22% of the strokes were happening because of AFib, which we didn't know about.
Wow, that's really good information to know. And I love the analogy that you use of the fish flopping. I feel like that's a good way that you can really know that something's going on. And sometimes you might not feel anything until it's too late, right?
Right.
And so what are some risk factors that, people can look out for and maybe know that it's time to get checked?
Yes. So atrial fibrillation used to be disease of elderly. And as every other disease, the demographics have shifted. So we are seeing more young people with AFib. We see also sometimes very young, like patients in 20 years of age or 30 years of age with atrial fibrillation. Many of them have genetic conditions. So that is one risk factor, so to speak. People are born with some inherited condition that runs in their family, and that can put them at risk for atrial fibrillation. So that is one risk. The other risk factors, most of them include alcohol. So heavy drinking can cause atrial fibrillation, uncontrolled blood pressure, uncontrolled diabetes, uncontrolled acid reflux problem, sleep apnea and weight gain, which comes together most of the time, can cause the atrial fibrillation as well. And one aspect we notice, I have a few patients we follow who are actually marathon runners, so healthy people, but very heavy training in running or bicycling. They can have atrial fibrillation too for different reasons, but yes. Which is actually more easily treatable because you just have to detrain and back off on the training, and the AFib sometimes goes away. So those are some of the most common risk factors. But any kind of uncontrolled heart disease, so to speak, can lead to atrial fibrillation. Many times you have a surgery or infection. You have a bacterial infection in urine, you have a pneumonia or COVID and flu. They can trigger AFib as well. So many patients we see in the hospital, they came for a different reason, but now they have atrial fibrillation. And most of those patients get treated for their primary cause, which is infection, and then we treat atrial fibrillation on the side and then see if the atrial fibrillation pretty much goes away or not. But most of the time, as I said, the atrial fibrillation, you acquire some kind of baggage in your body, over time that causes AFib.
Wow. And you mentioned some ways that maybe you can prevent AFib, maybe by controlling whether it be your blood pressure or, anything of that sort. Are there ways that you can prevent this?
Yes. So controlling the risk factors, that is always the priority. So in case somebody has blood pressure, we want to make sure it is controlled. Somebody has diabetes, we want to make sure it's controlled. Acid reflux, which kind of slips under the radar, but has caused atrial fibrillation correlation in the studies, so that we need to control that as well. Sleep apnea, there is more awareness of sleep apnea now than it used to be a couple of decades ago, but still a lot of that is under the radar and gets missed. So that needs to be picked up as well and treated. Unfortunately, treatments for sleep apnea come with a CPAP machine, which is not very desirable. There are new techniques and treatments for that. So definitely, I think, people shouldn't be shy away from getting diagnosed and then seeking treatment for sleep apnea. Then, if nature has a bad hand in terms of a genetic issue, then we can't control it, obviously. But even then, we can treat it early. So that's the other part of prevention, is treating early. So prevention not always is that we can absolutely prevent any kind of problem, but also prevent the consequences of that problem. So AFib, if it happens, we don't want to wait till it causes heart failure or causes a stroke. So we catch early, treat early, and that has been the shift in the last 10, 15 years in our field, that we catch it early, treat it early, so that the next 20, 30 years of life are better.
Absolutely. Bringing awareness to this too can definitely bring light into this for more people going in and getting checked and being proactive about your heart health, rather than reacting while it's, unfortunately could be too late. But what goes into the diagnosis of AFib? I know you mentioned EKGs earlier. Are there anything else that entails the diagnosis?
Right. So EKG is just a 10-second snapshot of your heart. And when you do it, if you're in atrial fibrillation, we'll catch it. But atrial fibrillation notoriously comes and goes. And about 70% of the people have it the way that it can last for a few hours, sometimes a few minutes, sometimes a few days, and may or may not make you feel bad. So it gets ignored or not diagnosable. So what we do in those cases is, in addition to EKG, if we don't see it, but patients have complaints or we have suspected AFib, then we can put monitors. And monitors come in different shape and form. Some are done for a few days, some can be done for a few weeks. And then we have some implanted monitors under the skin, which have become very, very small these days and can last for a few years. And those especially are preferred in patients who have stroke but have not been diagnosed with atrial fibrillation, or some people who have been treated for AFib and now they don't have AFib. So we want to see when they become again risk of AFib or risk of stroke. So we put an implanted monitor in those patients to kind of watch it for long term.
That's phenomenal. And what goes into the treatment of AFib?
So sometimes you don't need a treatment. Very young people, no risk factors. They have no diabetes, let's say, no hypertension, no other genetic issues. Then you have AFib for a few minutes once a month. You don't need treatment. You can just control your lifestyle. No medications are needed if the risk of stroke is very low. So, but that also needs to be evaluated. Not everybody can make that determination. So it gets very important to make that determination that somebody indeed is a low risk for stroke and we don't need to treat it. Other than that, majority of the patients will need treatment for risk of stroke. So we prevent risk of stroke by blood thinners and then treat the atrial fibrillation on the side to prevent it from happening a lot or bothering the patient a lot or causing heart to get weak in general or increase the risk of stroke. So if we decrease the AFib, risk of stroke decreases for the most part. There is still some risk of stroke inherently because of what's going on in the heart. So not everybody will have a risk of zero when we control AFib, but most people will. And treatments include, for atrial fibrillation, there are certain medications. We use some very mild medications to start with. Then we have more specific medications that only affect the rhythms in the heart. And then we have procedures called ablation, which can be done as well. And ablation has been for atrial fibrillation around since 1980s, and the techniques and technology have improved significantly over time to the point that it used to be a 6-hour procedure about 10 years ago, and now it is an hour and a half procedure.
Wow. And I know that you're about to actually reach your 1,000th AFib ablation. Can you tell me what this milestone means for you and your patients?
Yeah, I found out this year that we were reaching that just while doing, work every day. It just feels like yesterday when I moved here in 2017 and started our ablation program, and with the help of my colleagues, my partner, Dr. Abun, and all the staff at Terrebonne and CIS, I think we have made this possible to reach this level of expertise, availability in the bioregion. And very exciting times ahead. We have more technology coming for ablation, which will make it even safer and faster to do it, and easier recovery for the patients as well. We already started shifting a lot of new technology in our practice in the last 5-6 years. We used to keep patients for atrial fibrillation overnight in the hospital. Now we don't have to do that for the last several years. And we were only able to do 1 or 2 ablations a day because they were lasting longer. And now we can do up to 3, sometimes 4. So that has definitely improved looking back at, all these 1,000 ablations. And definitely very exciting, but wouldn't have achieved it without the support of all the staff at Terrebonne General and CIS.
Okay. So The way technology has evolved has been so amazing, and I love that you mentioned all the different treatment options available. And some people may not need any kind of treatment. Some people may just have lifestyle modifications as their treatment, some medication. Some might need the procedures, but those procedures are so minimally invasive, and I bet it makes the recovery time so much faster in that regard too.
So the AFib ablation procedure has evolved and gotten to the point that we're, as I said before, we're sending patients home same day, and we don't use any additional urinary catheters that were needed before. So that decreases the recovery time tremendously, and less risk of complications as well. So most people actually return back to work within 3 to 5 days. And I usually tell them to 3 days, take it light and easy, no heavy lifting. And then after that, they can start doing more. And by 5th, 7th day, they can pretty much resume normal activities and work. So recovery definitely has improved and helped us to take care of patients more efficiently and better.
This is really amazing to hear how things have evolved. And so is there anything else that maybe people should know about AFib?
Yeah, I think mostly the issue with AFib is underdiagnosis still. It's one of the most common arrhythmias, and I think many people are just not aware of it or having it. And then there has been more awareness in the physician community, so many people have been diagnosing it a lot more, especially our primary care physicians have done a tremendous job here in Thibodaux and Houma to diagnose a lot of patients which would have been missed before. So I think kudos goes to that as well. And in addition to that, also referring the patients earlier, even though they may not need a whole lot of different treatment options, right. But it is better to get evaluated early on to make that plan. I think very important to have that electrophysiology consultation to make sure that the treatment is right. And most of the time, they may not need to see multiple cardiologists. They may just need to have one visit, make a plan, and then go back to your regular doctor. But I think that is where a lot of reservation may still be present, that, rather than seeing 3 doctors, I don't want to see only one. So, but it's important because everybody has a niche now, and the diagnosing and treating is very different in rhythm disorders than the regular heart issues. So once a plan is made for atrial fibrillation, every other doctors can run the plan for the rest of their lives.
That's really incredible, and it sounds like a lot of personalized treatment plans and care plans are made from this, and that's very important here at CIS, I know. Well, thank you so much for sharing your insights with us today, Dr. Singh. We loved having you on the show.
Thank you. Yeah, it was a pleasure to be here.
We hope that this has empowered you on your health journey. If you have health concerns, visit cardio.com to learn more or request an appointment. Make sure to follow this podcast as well as CIS on social media for updates. Thanks for listening.